Today's talk is going to be on contrast media. This is going to be iodine-based contrast media, and we're going to be concentrating on intravenous and intra-arterial injections. Let's do a little review for those of you that know something about contrast media. If you remember correctly, we have two main categories. We have positive contrast media, and that is going to show up, that's going to be radio opaque. In other words, it's going to absorb radiation. And then we have negative contrast media, and this is going to be gas-based. CO2 or air would be used, and it's going to be radiolucent, so it shows up differently. Remember, contrast media, the whole purpose of it is to increase radiographic contrast. Introduction. In angiography, iodine-based contrast media use is a requirement. In this lecture, the learner will be informed of the varying types of contrast media and the possible allergic reactions related to them. Objectives. Upon completion of this lecture, the student should be able to, number one, recall terminology related to iodine-based contrast media. Number two, identify various types of iodine-based contrast media. Number three, identify risks related to using iodine-based contrast media. And number four, recall steps in the event of an allergic reaction. We're going to start off by talking about concentration. And this is going to be the amount of salt in the solution. And it's going to be expressed in weight of salts per 100 mLs of solvent, usually in grams. What you need to remember, as the concentration increases, this means we have more solute in the mixture, and so as concentration increases, viscosity increases, and viscosity is going to be the thickness of the concentration. You can take a look at the different labels. If we look at ISOView 370, what it's saying is that 37% of the concentration is iodine, and then we have Visopaque 320, and that's going to be 32% of the solution will be iodine. Miscibility is the ability to mix or blend with other substances. If you take a look at this image, this is a satellite image of the disaster we had in the Gulf back in, it was about 2008 or so. You can see the big oil spill out there. Oil is not miscible with water, and so they do not mix together. But if it was vinegar, it would mix together. So do we need to have it to where contrast media will mix with the blood? Certainly. If it doesn't, let's say it was oil-based and it doesn't mix with the blood, what would happen is you would end up with emboli at the arterial and capillary levels. Persistence. Persistence is how long will this contrast remain in the organ or in the patient's body. We've all got relatives like Uncle Eddie from Christmas Vacation, but I kind of think of it this way because they're the ones that never go away. Yeah, they're very persistent. We want to have the shortest persistence possible. However, the contrast does have to stay in the patient's body long enough for us to gather the images. A perfect example is a double contrast barium enema. Once the radiologist is finished with their fluoroscopy portion of the exam, then we do overhead images, and between each exposure that's made, you have to give 2 puffs of air into the colon, and it's because it's being absorbed by the body. So it's not real persistent. Okay, so iodine content in the medium. Okay, the reason we use iodine is it has an atomic number of 53, so it's going to absorb 5 times the amount of X radiation as what soft tissue would, and 3 times more than what bone would absorb. You have to remember, even if it says it's non-ionic, it is still, all IV contrast medias contain iodine. And you also want to remember that an increase in iodine content increases the radiopacity. So in other words, the more boldly it will appear in the image. We have 4 different contrasts that we will visit. Actually, we're going to visit 3 of them. First of all, we have the ionic. These are listed from the most toxic to human tissue to the least. So we have ionic. This is a contrast that has not been balanced out. The iodine hasn't, and so it's got a very high milliosmolality. We have non-ionic contrast, and then we have low osmolality ionic, which is Hexabrix, and then the real go-to anymore is an isomolar non-ionic, and it's Visopaque. Ionic contrast media is going to have anywhere from 1,000 to 2,400 milliosmoles per kilogram. Now let's put this into perspective. The average milliosmoles per kilogram of the human body is about 300. So what we're looking at here is a hypertonic solution. In other words, it is if you remember right, if you take and put cells in a hypertonic solution, the water is going to cross the semi-permeable membrane, and the cell can crenate and die. If the cell is put in a hypotonic solution, then what's going to happen is water will cross into the cell, and it can cause them to burst. So we want to have as close of milliosmol per kilogram as possible. One of the things that happens here is we have the highest likelihood of these different reactions. Metallic taste in the mouth, and that's because of the iodine. And what it tastes like is putting a penny or a nickel in your mouth and sucking on it. Just about every single patient, when you inject them with this contrast media, will have a hot flash. In the veins, it can actually burn, give a burning sensation. And when injected into coronary arteries, it can give an arrhythmia. There was a contrast that was used, it was around 2000, pre-2000, and every time you would inject it into I say every time, frequently when you would inject it into the right coronary artery, the patient would have some sort of arrhythmia. And it was even to the point that every single patient that we put on the table, we would tell them, if we tell you to cough, we want you to cough hard. And we were trying to have them convert their arrhythmia back into a normal rhythm. The next contrast that we're going to look at, or the next category, is non-ionic. Now notice that the milliosmoles per kilogram is now 750, so now it's closer to what the human tissue is. And so we can still have these reactions, but they're greatly reduced. And that's going to be, they might have a slight taste of metal in their mouth. They might get a little bit of a hot flash, but not much. The burning is reduced immensely, and the chances of arrhythmias are greatly reduced. So then we get to the Visipake. Now, Visipake has, it's 290 milliosmoles per kilogram. So now we're right at it's almost a hypotonic solution. And so you have the least chance of reaction with little or no metallic taste, hot flash, burning, or arrhythmia. First time I ever saw it used was at a VA hospital with a radiologist that we were recruiting to come to our facility. And he put this gentleman on the table. He was going to do a lower extremity runoff. This is a long, it's 10 to 11 second injection at 8 to 10 milliliters per second, and you chase the contrast down the legs. Now, the times that I had done these exams previously, we were using the non-ionic contrast, and we would have to tell the patient, don't move. We'd heavily sedate them, and then we'd have to tell them, don't move. You can holler at me. This is going to burn like fire, but then it's going to go away. And so this radiologist didn't even sedate this patient. And I was thinking, boy, this sure is going to be bad. And they told him, okay, hold still. They made the injection, and the gentleman did not have any burning or any discomfort whatsoever. He didn't realize that anything happened. One of the labs, or two of the labs that we have to draw before giving iodine-based contrast media, is going to be the creatinine and the BUN, or blood urea nitrogen. And the reason for this is the contrast is going to be excreted through the renal system. Now, in some cases, for arterial injections, they will take and use CO2. And CO2, it looks just like air, so it's kind of frightening the first time you inject it into an artery. But the way CO2 is going to be excreted, and the reason they use CO2 is hemoglobin has an affinity to pick up oxygen and transport oxygen, and also an affinity to pick up CO2 and transport it. And so if you have a CO2 injection into your arterial system, it's going to be excreted when you exhale, okay? So the creatinine levels that are considered normal is going to be 0.6 to 1.3 milligrams per deciliter. Creatinine is a measure of the byproduct of the metabolism of phosphocreatine, and it's a source of energy for muscle contractions. Increased levels of creatinine can indicate advanced renal disease. So it's the more accurate of the two labs. Now, the blood urea nitrogen, or BUN, the acceptable range, generally speaking, is going to be 6 to 20 milligrams per deciliter. And increased levels can indicate dehydration, decrease in renal function, or treatment with drugs such as steroids or tetracyclines. So when it comes down to it, a patient can come in, have a normal creatinine, but they're dehydrated, and so they have a raised BUN. So we would take and start an IV and hydrate that patient. So the creatinine is more accurate about the true renal function. If a patient has impaired renal function, we're going to hydrate them. Whenever they come down to the lab, they're going to have an IV running at about 100 mLs per hour. Okay, we want to increase urine output if possible. There's a medication that can be given, and I won't go into details about it, but it's just a really foul smelling and tasting medication, and that's Mucomyst. You would want to limit the contrast volume and then use Visipake contrast media. And then post-procedure, you would want to monitor renal function and also continue to hydrate the patient. We're going to take a look at the different types of contrast media reactions that can occur. Before I go into that, though, I have some really important information to give you. You want to write this down. Reactions, 70% of the reactions, allergic reactions that patients are going to have post-injection are going to be within 5 minutes. So 70% of the allergic reactions will occur within 5 minutes of the injection. 16% of these reactions will occur between 5 and 15 minutes after the injection, and 14% of patients will have an allergic reaction 15 minutes post-injection. So you can see the last thing you ever want to do is inject contrast media into a patient and then leave the room right away. That's really poor form. You want to hang with them and monitor them. So you can see that we have two categories. We have minor and we have major allergic reactions. What you're going to see is minor reactions are going to be primarily skin reactions and GI tract. In other words, nausea and sometimes nausea and vomiting. So we'll take a look at these minor ones. And what are we going to do with these? Well, you might give some IV Benadryl and perhaps some steroids. If we look at major reactions, this is going to be respiratory and nervous system. And so you can see here coughing, shortness of breath, wheezing, syncope, shock, stridor, and even seizures. Yeah, and what you're going to be doing here is you're going to be monitoring the airway, watch their breathing, you're going to monitor their circulation, and in some cases you're going to have to perform CPR. Rash. This is a general term for any eruption that appears on the skin transiently, as opposed to durable skin lesions such as scars, tattoos, or moles. Just think of a rash as you change a laundry detergent, or you change your soap, and you get that itchy feeling and your skin just feels irritated. That would be considered rash. Urticaria. This is multiple swollen raised areas on the skin that are intensely itchy and last up to 24 hours. They may appear primarily on the chest, back, extremities, face, or scalp. Now, what you want to remember with this, if you take a look at the areas that this will show up, it's all tender skin areas, and it's think of it as being a rash, but a rash on steroids. It's going to be a little more intense. If you look here, this is Latin for needles or nettles. Think of stinging nettles if you've experienced that. That would be urticaria. And then the third level of the skin reactions is going to be pruritus. Okay, and this is Latin for itching. And it's an itch or a tingling or faintly burning skin sensation that prompts a person to rub or scratch. And you can see here it's quite a bit more intense. We have flushing. Flushing is not a real skin reaction. This is you have somebody that you have a crush on them and they walk in the room and your face gets red. Yeah, that would be flushing, and it's transient. Remember, when it comes to reactions, minor reactions primarily consist of skin and stomach reactions. And we'll take a little bit more look at that. And then we have major reactions. They can include minor symptoms. However, They involve the respiratory, circulatory, and or nervous system. So it's more extreme for sure. So treating the mild reaction, what you're going to be dealing with primarily would be nausea and vomiting, and this is usually self-limiting. However, you can give an antiemetic if the doctor orders it, such as Zofran or Napsine. Now hives, you could give IV Benadryl. Sometimes they'll order IV Pepcid, and the reason for that is histamine is what stimulates the acid pumps in the stomach, and so if we suppress that, we'll reduce the histamine response, which is where we have the allergic reaction. And then we have Solumedrol, which is another steroid that you can give. Now, while you treat minor reactions, always assess symptoms for moderate to severe reactions. Now, this is one of my favorite slides in all my presentations, and I just love those two little cubs. And so I think of them as being minor reaction. The patient's vomiting, then they have a rash, and then they start to complain of shortness of breath. You're going to be watching for it. So whenever there are two cubs around, mama bear is somewhere, and she would be the major reaction. Treating the moderate reaction. Okay, this would be mild bronchospasm. In other words, tightness of the chest, wheezing, mild facial or laryngeal edema, or isolated hypotension with tachycardia. Now, why would the patient become tachycardic if they have hypotension? It's really simple. The body is trying to stay in hemostasis, and if the blood pressure drops, there are three ways we can increase this blood pressure. Now, write this down. The three ways you can increase blood pressure in a hypotensive patient is: number one, increase the volume in the system. In other words, give them a bolus of normal saline. Number two, you can increase the heart rate, and you can do that with atropine. You could, which will increase the heart rate. And number three is to constrict you want vasoconstriction to make the system smaller. And for that, you would use something like dopamine, epinephrine, or vasopressin. And these will cause that tunica media to contract, making the vessels tighter and thus bringing the pressure up. So the three ways you can increase a patient's blood pressure: increase the volume, increase the heart rate, make the system smaller. So what are we going to do? We're going to be giving O2. You're going to give 0.1 milligrams of subcutaneous epinephrine, and that's 1 to 1,000 strength. So this is going to go into that fatty subdural fat layer, and it's going to be 1 part epinephrine to 1,000 parts saline. You could give Solumedrol. Now, you're not going to be doing this by yourself. You're going to have a physician involved at this point. Solumedrol, and that's to fight that or suppress the allergic response. And then a saline bolus, and this is to bring that pressure up. And in this case, we have dopamine written here, and that's to constrict the vascular system. Treating a severe reaction, this would be severe bronchospasm or laryngospasm and profound hypotension. Very first thing you do is call a code. You don't want to start anything until you call that code so you have support. You're going to do all the same things as what you would for moderate reaction. However, you're going to get very aggressive with your oxygen delivery, with your bolus of normal saline, and your use of epinephrine. Now what's going to happen is we're going to give 1 milligram of IV epinephrine with a mixture of 1 part epi to 10,000 parts saline, and this is going to be IV. You're going to prepare for intubation, and if needed, you would initiate CPR. In the case where a patient ends up with seizures, if that were to happen, the medication you'd want to use at that point would be Valium. That will calm that seizure down in many cases. So if a patient has a known iodine allergy, does that mean that they cannot have contrast media? No, it doesn't. We would just pre-medicate a little more aggressively. You pre-medicate 1 to 3 days prior to the procedure with prednisone. Prednisone is going to suppress, it's a steroid that will suppress that immune or that allergic response. When the patient is in the hospital preparing for the procedure, the cath crew will call report and then call for pre-meds to be given, and at that time they'll give them the Benadryl. They might give them Solu-Cortef, it's another steroid, and IV Pepcid. If you have a known allergy, they want to use that Visipake. It's the lowest osmolality contrast media that we have. So when administering contrast, you want to communicate with your patient. You want to collect an accurate history. When communicating with the patient, I'm going to back up here for a moment. When communicating with your patient, you're going to be setting them at ease, and you're going to explain, here's a sensation that you may experience. Here's what this might feel like, and you give them an idea of, and just kind of talk them through. You want to collect that history, asking about what they are allergic to. And then, like I just said with the communication, explain the sensations that they might experience. And then, as you're giving the injection, you want to ask how they're doing. And after the injection, you want to be watching them. And, it's something as simple as all of a sudden they go, oh, my nose is starting to run. Or they might sneeze. Or they might cough. Then you're going to be asking, how does your breathing feel? Can you take in a deep breath okay? So you want to watch, listen, and communicate with your patient. And then after the procedure, you want to remind them to hydrate. Yeah, have them take in extra water for the day, and that will help clear the contrast from their system. And remember, you're only a student. And what I mean by that is if you're uncomfortable, if you have a doctor that says, go do this, make this injection, and you're uncomfortable with it, you can ask for help. That concludes this talk today, and I hope you enjoyed it.